Hello, everyone. Welcome to our Zoom meeting. Today we will have a couple of topics, but before we start, I'll hand it over to Dr. Yaqeen and Rayan, who will moderate this meeting. And would like to congratulate Dr. Myra, who
Thank you.
was accepted to residency program in psychiatry. Thank you all, and you can go ahead, Dr. Myra, when you are ready, and then the moderators can jump in. Thank you.
Absolutely. Thank you. Thank you, community. How are you? I'm so grateful of you having this time and opportunity to share my experience, as Dr. Nadir said. Um, this is really I did match in psychiatry here in Florida. It's been my dream since like maybe 7 years ago. But finally, after I finished my exams, I really pursued that I wanted to do psychiatry. And as you guys tell, I applied for the 2025 match. That was my first match, and I didn't match on this year. And then after they told me from friends that that this one was a new program in psychiatry, and they already have 400 applicants. It was really competitive to get in, but it's not what you do with the person that you know, and how you present yourself. It's really important for us to do that. And I didn't. I'm from Venezuela. I am G from Venezuela. I didn't know how important is the connections. Like someone that put a word from you, a program director that speaks to another, an attending that sends an email to you. That was like what helped me the most to get this position, and I'm extremely grateful for. I'm starting in July. I'm currently working as a mental health counselor, crisis and mental health counselor. Just be my biggest advice with you guys: be intentional in what you guys pursue. If there is a specialty that you like, go for it. O sea, do research on it. Go and work, even if it's as a medical assistant, even if it's like whatever it needs to get involved in the area. Like in my experience, I went from working in as a medical scribe, as a medical assistant in a psychiatry office, to working as a in the psychiatry department in the emergency as a counselor, and then to meet the people I needed for get the reference and the letters, and to get to the place that I am right now. I'm starting residency, and to just be really consistent in what you put your intentions in. My biggest advice: yes, exams are important, yes, but prepare yourself for it, like manifest it. I'm bigger on like the people speak. Don't be afraid to like ask people like what I need to do, what is the best next step, how I can get more involved, not only in this group, in other research groups. Like I literally contacted like, I don't know, 50 people a day in LinkedIn to see what opportunities they could offer me. If it's necessary and you have to do an externship after your year, do it. So don't be afraid. I know it's a long process, it's a lot of money, but it will pay it off at the end. Just don't be afraid. And if in any of you guys are interested in psychiatry, well, this is my information, my number, and it is important. For me, it helped me, the persons that I knew, and be really intentional in the specialty that I wanted. I always say that if I wanted to match, I was going to apply to psychiatry until I made it. And well, thanks God, I only had to apply 1 year, and I got it. I'm extremely grateful now. If you guys have any questions, well, I'm more than happy to answer them right now.
Thank you so much for sharing your experience and tips and advice. And if you can share your email in the chat, so anyone with questions down the road, they can reach out. But thank you.
Absolutely, yes, yes. And that's my biggest advice, Dr. Nadi. Like, keep connections, like do this, speak, like reach out to people. Like you gave me emails from other fellows the previous years, and I contact them and we speak. And people give you like a roadmap. Like, it's not a straight path, but you just have to like get that advice from anybody, like, and study really hard. Like, don't worry if you fail an exam. I failed an exam, and be honest in your personal statement and why do you did it. And they asked me, and just be yourself. Like on my interviews, I was always myself, my true self. Like, do not get, well, what I do all day speaking with people. Just maybe I'm a little bit more used to it to speak and present myself. But be yourself and be honest about. They know that as an IMG, the best thing that we have is our life story. You know, we have amazing life stories. This is just be yourself and try to share those life stories because they want to hear it. They really do. And if it's a specialty like psychiatry, definitely they want to know. They already know your scores. They already know um, that you're qualified to be there. They just want to know if they want to work with you. If you are not, if you're a person that is gonna be a resident that is gonna put the hard work, that is gonna resident, that is gonna show on time, that is gonna be a resident that is used to work in teams. They just want to know if they're gonna be able to trust in you and work with you. It's the most important thing. Don't be afraid of that. Just be who you are, and that's it. I will do it. I will put my email right now.
Thank you. Did the
Thank you.
research help you? Did this fellowship help you in any? Did they
A
ask
lot
you?
because yes, they asked me many times, and because I was really intentional when I write my personal statement that because I was doing a research in geriatrics, I wanted my personal statement to align with it was really thought the way I presented. And when they asked me about the research, like why I was doing a research in geriatric, and I say that I wanted to become a psychiatry geriatrics, and I really I spoke about like that you create this group for international medical graduates to learn how to do research in America, and they were really interested about that. I told them like maybe we don't know like one-to-one research, like we're not like doing drugs research, but yes, like we know how to present cases, we know how to do systemic reviews, and like that you are involved and that we have things to present in conference. They were really interested. It was a plus in that because you're not in awe, like you don't have that gap. The Americans, they get formed in research, and sometimes in our country we don't do it that much. So it's really good that you can show that in your CV. And working in this research, it helped me to put it in the gaps that I needed for my CV, because in 2023 when I entered this research community, I was studying. Just I was like practically not putting things on my CV that I was like, but it helps to feel like, okay, I was doing research while I was studying, what I was, yeah, it helps. It helps a lot. And it's always, it gives you an opportunity to speak something. Have you done any psychiatry shadowing? I did here in Jackson Memorial and here in Miami. And I was planning my other biggest advice: go to the conference of the specialty that you want to, if you can. I don't know, many of you guys are not here present in the United States, but I think one of the things that opened my eyes, it was to go to the APA, that was the American Psychiatry Association. I went to the conference. I was there for 5 days, and you cannot imagine the connections that you make there. You get to meet program director 101. You get to meet residents in all the levels. You get to meet even the pharmaceutical representative. You just get involved. It is important. Yes. No, thank you, because they really asked me questions about this. And what geriatrics, because it's like there is such an underserved population, and in psychiatry more. So she's like, why? And I'm like, well, it makes me to show how intentional I was with my plans. Yeah. Thank you.
Thank you so much, and we wish you all the best, and be in touch.
Of course, definitely. If anybody you have to ask me a question, reach me from my WhatsApp. I'm gonna leave my phone number, and you can text me there.
My question,
course.
last one. How to say good luck in Spanish?
Buena suerte.
Buena suerte.
Buena suerte. Thank you so much.
Muchas gracias. Thank you.
Hello?
Hello, Dr. Ahmed, or
Yes. Um,
welcome, Dr. Ahmed. Go ahead.
Hello, everybody, and congratulations, Myra. This is really incredible achievement, and this is great story, and you are a role model for your colleagues, and I'm sure this is just the beginning, and you are gonna succeed in your coming academic life. This is really great, and we need to be persistent in pursuing our goals. Each one of you has incredible story, and I remember the first time I have been in the United States, I work as in behavioral therapy, and just you remind me of the psychiatry. So I was in the field of doing behavioral therapy. I was later work as behavioral specialist consultant dealing with kids with oppositional defiant disorder, ADHD, and conduct disorders. And that really later in life helped me to join internal medicine. But like a story like yours is really resonate with most of us. Good luck and keep going. And I wish the best for all our fellows. And life is a big story, and working hard is really the key, and the persistence is a key. And thank you for sharing your story. This is really great. Thank you, Nader.
You're welcome. Thank you, Dr. Hammond. More than happy to help to anybody that needed.
Dr. Nader, sorry, but your microphone is off.
Thank you so much, Dr. Myra. Thank you, Dr. Naima. We wish you all the best, and now we can start our topics. And Dr. Yaqeen and Rayan, please take it over from here. Thanks.
Hello, everyone. Assalamu alaikum. Is my voice clear?
Yes, it's clear, Dr. Yaqeen. Go ahead.
Hello. Hello, everyone. My name is Yaqeen Kamal Bilal. Today, me and Dr. Rayan, we will present diabetes mellitus. Okay? I will start. The objectives of this topic to know and understand the consequences of diabetes in older adults, how to establish a diagnosis of diabetes, managing hypertension, dyslipidemia, and microvascular complication in patients with diabetes, doses and formulation of the anti-diabetic agents. We will cover epidemiology of diabetes, the consequences of diabetes, and the classification of diabetes, the pathophysiology of diabetes, and the diagnosis, and the managing, and how to manage the complication, and the education and self-management support. Okay? The diabetes affect around 15 to 20% of people more than 65 years, one of the most common chronic diseases in that age group. Age-adjusted prevalence higher among Black and Hispanic Americans than white Americans. the consequences of diabetes that it reduction 10 years in the life expectancy. So it have higher mortality rates, higher risk of atherosclerosis, neuropathies, and high risk of myocardial infarction, stroke, and kidney failure, 40% high risk of blindness, and high risk of mobility disability, and high risk of disability in the activities in the daily life living. So it's a very important thing to consider, and it's one of the most important chronic diseases. So older adults with diabetes at a higher risk than those without diabetes for genetic syndromes, including incontinence, depression, cognitive impairment, urinary incontinence, injurious falls, and chronic pain, and also polypharmacy. So what are the classification of diabetes? We have two types of diabetes, and we have a third category here. Okay, type 1, it results from absolute deficiency in insulin secretion. Like we don't have any cells that secrete the insulin. So it's an absolute deficiency in insulin secretion due to an autoimmune destruction of pancreatic B cells. Type 2, it's always resistant, okay? Usually due to tissue resistance to insulin action and relative insulin deficiency. What is the third category? That we have injury to the pancreas, endocrinopathies characterized by excess of hormones that antagonize insulin action, drug or chemical-induced diabetes, and infection that destroy the B cells. Okay, so most of it is an injury. Okay. What are the pathophysiology of diabetes in older adults? About 90% of older adults with diabetes have type 2. Most of them have type 2. And in the children, it's most common to have type 1. The diagnosis usually follows years of pre-diabetic. Glucose intolerance, insulin resistance, metabolic syndrome. Pre-diabetic itself is very important because it's arise the risk of atherosclerosis. Prevalence of both type 2 diabetes and glucose intolerance increase with what? With age, genetics, lifestyle, influence of aging, certain medications, intercurrent illnesses, and other psychological, physiological stresses. Okay, so now the pathophysiology of diabetes, that we have insulin resistance. How that? The body cells, like muscles and the fat and liver, responding well to insulin. Glucose cannot enter the cells easily, so it stay in the blood. So we will already have a high blood sugar. That will lead to a physiological response that the insulin production will increase, right? So the pancreas work harder and harder. It makes more insulin to overcome the resistance. This helps at first, but is not sustainable. Third thing will happen that the beta cell that secrete the insulin will get exhausted. So over time, the insulin-producing cells in the pancreas become tired and weak. Less insulin is produced that will lead to blood sugar rises even more. The liver overproduces glucose. Why? Because the insulin normally tells the liver to stop releasing glucose. In type 2 diabetes, the signal is weak, so the liver will keep adding more sugar to the blood. The fat tissue worsens the problem because the excess fat release inflammatory substance. These chemicals make the body more insulin resistant. We also have protein metabolism is affected. Why? Because the insulin normally helps build protein and prevent muscle breakdown. So, in conclusion, in type 2 diabetes, we have insulin resistance, reduced protein building, more muscle breakdown happen, amino acid from protein breakdown can be used to make more glucose that will worsen the blood sugar. So in the end, the result is going to we have chronic high blood sugar. Okay, now we want to know how we diagnose diabetes. We have 3 ways to establish the diagnosis of diabetes. Depending on the symptoms, like polyuria, polydipsia, and unexplained weight loss. And they always complain of unexplained weight loss, plus casual plasma glucose. Casual glucose, like if they take it any time of the day, it will be more or equal 200 milligram per deciliter, without regard to time since last meal. or the plasma glucose after an 8-hour fast equal or more than 126 milligram per deciliter, or plasma glucose more or equal to 200 milligram measured 2 hours after ingestions of 75 glucose in 300 milliwater administered after an overnight fast. Okay? Okay, so what are the pretending borderline results? That means the patient, when he will be a pre-diabetic, like a person who's pre-diabetic, he's not diabetic fully. He will have impaired fasting glucose. His fasting blood glucose will equal from like 110 to 125, associated with increased risk of diabetes, isolated post-challenge hyperglycemia, fasting blood glucose not elevated. Many of these patients would be diagnosed with type 2 diabetic by the oral glucose surveillance test criteria. Appears to increase risk of atherosclerosis, although is not much as type 2 diabetes. So the pre-diabetic, it also have a risk, as I said, to have atherosclerosis in multiple complications. What are the clinical evaluation of older adults with diabetes? Evaluate the risk factor of atherosclerotic disease and presence of comorbid diseases. Take also medication history, assess the functional states, screen for geriatric syndrome, and use the multiple medication. Does the patient have depression, cognitive impairment, urinary incontinence, and chronic pain? Assess need for diabetes education and self-management support, and whether to involve a caregiver. What are the goals of diabetes management? Control hyperglycemia and its symptoms, right? To evaluate and treat associated risk for atherosclerosis and microvascular diseases. Evaluate and treat diabetes complication. To support diabetes self-management and education. Maintain or improve general health status. So, the general principles of diabetes management: older adults should have the same opportunity as younger adults for intensive diabetes management, reduction of risk associated with diabetes, and treatment of comorbid conditions. For some older patients, intensive management of diabetes will not give a good result. So, we have to give the right medication and the right management. It's not likely to provide benefit and can be harmful. Diabetes management goals and clinical targets should be individualized. Thank you, everyone. Dr. Rayyan Badawi will continue with you.
Thank you so much, Dr. Yaqeen, for this great presentation. Hello, everyone. Hello, Dr. Nader, Dr. Ahmed, all the fellows. I'm Rayyan Badawi. First of all, congratulations, Dr. Myra, for the match, and for all the fellows who have matched it with their incredible stories. I'm so glad to be here today. I hope my voice is clear for everyone.
Yes, it's clear, Doctor.
Okay, just give me a second to share my screen. Okay. So just let me check. Does my screen appear for you, everyone?
Yes, Doctor.
That's great. Thank you so much. So thank you so much, Dr. Yaqeen, for doing the great presentations and putting the strong foundation for the diabetes mellitus. It's a very important topic, and it has a major significant impact on health, of course. So today I'm gonna continue the diabetes mellitus topic. My main topic, or my main presentation today, about comprehensive diabetes management, risk factor control, and therapeutic options. So the general, as mentioned, Dr. Yaqeen, the general principles of diabetes management is older adults should have equal access to effective diabetes care, and not all benefit from intensive treatment, avoid potential harm. What I'm trying to say here is that during the diagnosis, or when a patient is diagnosed with diabetes mellitus, each patient will differ from the other. Some patients could be diagnosed early and others could be diagnosed late. What I'm trying to say is that some patients will be diagnosed earlier without the complications. Some of patients will be diagnosed late, like with the development of complications and so on. So if we need to, if we are deciding to manage the patients with diabetes mellitus, we should know the individual status of each patient, because this will affect the treatment or the management for each patient. And another considerations that is very important is some patients with diabetes mellitus will differ in their life expectancy. If patients were diagnosed late, maybe after 80 years old, and they have like a life expectancy low, we are trying just to control the risk factors. We are not trying to do the intensive diabetes or intensive hyperglycemia control or intensive disease control, because sometimes in elderly people with other comorbidities, the intensive control of the hyperglycemia could lead to a harmful effect rather than a good benefit for the patient. So not all benefit from intensive treatment. I mean, the elderly people, not all of them will benefit from intensive treatment. Some of them could receive the intensive treatment as elderly people with a lot of comorbidities. So the restrict control or the severe control or intensive control of hyperglycemia could lead to harm. So individualized goals based on health status and comorbidities is very important. Sorry. So preventing and managing cardiovascular risk factors. You know that diabetes mellitus has many complications. Some complications, we call it as macrovascular complications, and the others are considered to be microvascular complications. So we need to control these complications in order to make a better prognosis for the patients. So promote healthy weight, physical activity, and smoking cessation. All this could be or could control the prognosis of diabetes mellitus, and advise dietary changes, reduce fat and carbohydrate intake. Also use medications when needed, like antihypertensive statins and aspirin. Patients with diabetes mellitus and concomitant hypertension, they could have a higher risk to develop cardiovascular complications. So we need to treat the comorbidity in order to decrease the risk of the complications. So management of hypertension in elderly or in older adults with diabetes mellitus, it's very important, as I mentioned, because hypertension with diabetes mellitus could have a very negative impact on the cardiovascular health. So as general, the elderly people, we are trying to control the blood pressure to be less than 140/80. And if we tried, or if we control the blood pressure to be less than 130/70, that would be very beneficial for patients who have hypertension and diabetes mellitus. This will decrease the risk of cardiovascular complications. So we will try to lower the blood pressure gradually to avoid adverse effects, of course. And ACE inhibitors or ARBs offer added cardiorenal protection. Of course, all of you know that patients with diabetes mellitus plus hypertension, if we need to control the hypertension in diabetes mellitus, we have a variety of drugs, but there is a certain drugs that could have a very beneficial effect in diabetes mellitus. Of course, you know, ACE inhibitors and ARBs could have a cardiorenal protection, because people with diabetes mellitus could have a possibility to develop nephropathy. So if we need to control the nephropathy, we can give the ACE inhibitors or ARBs, because it can act in the afferent arteriole of the kidney, arteriole of the kidney, and if it acts there, it will try to decrease the GFR. And people with diabetes mellitus have higher GFR. That means the proteins will be secreted in the urine, and this will lead to the development, of course, of renal nephropathy. And if we want to control that, we can use the ARBs or ACE inhibitors, because they have the same effect as general. So ACE inhibitors and ARBs could have an added cardiorenal protection in patients with...
Dr. Ryan, sorry, but the screen has been stopped sharing. Sorry.
Okay, I'm sorry. Just let me show it again. I'm sorry for that. It's like a technical issue. Tell me if it appears again.
Yeah, it's up here.
Thank you so much. So I was talking just about the management of hypertension in older adults, and we mentioned that ARBs and ACE inhibitors are very good for patients with hypertension and diabetes because they have a cardiorenal protection. So also, we will go to the managing hyperlipidemia in older adults with diabetes mellitus. So we are aiming for low-density lipoprotein less than 100 milligram per deciliter, and initiate the treatment if LDL was more than or equal to 130 milligram per deciliter. We are trying to control the hyperlipidemia in patients with diabetes mellitus because they have already a higher risk to develop atherosclerosis. With the other comorbidities that could lead to atherosclerosis, the patient will have a very high risk to develop the macrovascular complications like the CVA or the stroke, like the ischemic heart diseases, the peripheral arterial diseases, and so on. So we should start pharmacological therapy, statins, if we have hyperlipidemia, plus of course lifestyle changes. You know that statins as a drug, it can affect the liver, it can lead to hepatotoxicity. So as general, we need to do the liver function test as a baseline before starting the statins in order to check that the liver is functioning normally. So we should monitor liver enzymes, ALT, within 3 months or 12 weeks of starting statin, niacin, and of course annual liver test if on fibrates. You know, fibrates plus statin could be a good combination, but it has a side effect. Like after the liver toxicity, this combination, statin and fibrates, also could lead to myositis, the inflammation of the muscle. So we should also monitor for muscular pain or anything that related to the myositis. Of course, preventing and managing microvascular complication of diabetes mellitus. Well, you know, as I mentioned, and Yaqeen also said that before, the patients with diabetes mellitus have macrovascular complications and microvascular complications. The microvascular complication represented by the retinopathy, neuropathy, and of course nephropathy. So those patients with diabetes mellitus need to do the eye examination at diagnosis, and we should see the retina if there is any development of diabetic retinopathy. So eye exam at diagnosis is very important, and repeat early if retinopathy or symptoms or of poor control. Otherwise, we can do it every other year. Because patients with diabetes mellitus, of course, they could develop retinopathy, but there is other conditions in the eye that also could be associated with diabetes mellitus, like the cataract and glaucoma. So as general eye examination at diagnosis is very important, and then we can repeat yearly if retinopathy or symptoms of poor control or the other conditions that associated with diabetes mellitus. Of course, foot examination at least once annually, because due to neuropathy, the peripheral limbs, particularly the feet, could lose the feeling or the sensation. So the repetitive trauma could lead to ulcer or foot ulcer. So we need to do the foot examination at least once annually. And of course, screen for microalbuminuria at diagnosis and early. As I mentioned a few minutes ago, that nephropathy could develop due to diabetes, and particularly it will ultimately lead to nephrotic syndrome. It's associated with nephrotic syndrome. So if we want to decrease the progression of the nephropathy in patients with diabetes mellitus, we can control that by control the hyperglycemia itself, and also by giving the drugs that could be renal protective, like the ACE inhibitors or ARBs, and also give the pneumococcal vaccination any elderly people, any elderly patient with other comorbidities like diabetes mellitus will be at higher risk to develop severe pneumonia and complications of this pneumonia. So the pneumococcal vaccine, which is a vaccine against Streptococcus pneumoniae, which is one of the commonest bacteria that can cause community-acquired pneumonia, should be given to the elderly patients with comorbidities like diabetes mellitus to decrease the risk of severe pneumonia. Well, we can move right now to, if my screen is disappeared, just tell me. I'm really sorry for that. It's like a technical issue. Can you see my screen?
No, it's
Yeah.
not clear.
Yes, it's there.
Okay, so I should continue, right? Okay.
No, it's paused again.
I'm really sorry for that. It's like a technical issue.
Now it's okay.
Okay, thank you.
Now it's clear.
Thank you. So let's continue. Let's go to the pharmacological management of diabetes mellitus, the therapeutic classes and mechanism of action. So in the treatment of diabetes mellitus, we have in the pharmacological section, we have oral non-insulin agents, we have combination oral non-insulin agents, we have injectable non-insulin agents, we have insulin preparations, or these are classes of anti-hyperglycemic agents. So if you want to start the drugs and the formulation, it's better to understand the mechanism of action at first. Of course, all of you know that from the physiology, the pancreas is responsible for the production of insulin. So we have a specific cells inside the pancreas that called pancreatic beta cells. The pancreatic beta cells inside the pancreas are responsible for the production of insulin. In type 2 diabetes mellitus, our main issue is that the insulin is secreted from the pancreas, but the issue is that the skeletal muscles and the adipose tissue, we should have like a receptors for the insulin to work on the skeletal muscles and the adipose tissue, of course. But in type 2 diabetes mellitus, the main issue is that the receptors are not working. We have insulin resistance. So the insulin is secreted from the pancreas, but it cannot work on the receptors in the adipose tissue and skeletal muscles. So this will lead to the buildup of glucose in the blood, and it will lead to hyperglycemia, of course. And hyperglycemia has a variety of complications, as we mentioned earlier. So if we want to treat the hyperglycemia of the diabetes mellitus, particularly type 2, the oral anti-hyperglycemic agents should work to increase the level of insulin in the blood. If we have a higher level of insulin in the blood, that could have the possibility to overcome the receptor's resistance. So we have many category of drugs that act on the pancreatic beta cells to increase the secretion of the insulins. The first one is the sulfonylureas. Every one of you knows that, the sulfonylurea and their mechanism of action. It acts mainly in the pancreatic beta cells to increase the secretion of insulin. And also we have another type of drugs that acts similarly like the sulfonylurea, which is the meglitinide. It acts by the same mechanism of action. It will increase the production of insulin from the pancreas. So if we can see here, we can start with the second generation sulfonylureas. So we have the drugs and the dosage of the drug and the formulation and the comments, of course. We have the generic name and the trade name. All of you know that the glimepiride is a part of the second generation, or it's a component of the second generation sulfonylureas. The glipizide also, we have the glimepiride and the other drugs. All of these drugs are a part of the second generation sulfonylureas, with each one has its specific dose, of course. The most important thing that we need to know here is the sulfonylureas are secreted through the kidney and metabolized through the liver. So if there is any renal or hepatic impairment, that could lead to toxicity of the drug. For instance, if a patient with diabetes mellitus has chronic kidney disease or any renal impairment, that could lead to a decrease in the clearance of the sulfonylureas. And this, of course, will lead to a buildup of sulfonylureas in the blood. And based on that, the patient will be at high risk to develop hypoglycemia. So the glimepiride, it has long-acting and it has also drug interactions. The glipizide short-acting, glipizide XL long-acting, the glimepiride and the other drugs are long-acting, so increase the risk of hypoglycemia. We have the meglitinide, which acts similarly as the sulfonylureas. So we have also the generic name and the trade name. We have the nataglinide and ripaglinide. The dosage of nataglinide 60 to 120 milligram. It should be taken before each meal. It could be taken TDS, and ripaglinide also 0.5 to 2 milligram. It's in the form of tablets, of course, 60 to 120 milligram, here 0.51 or 2 milligram. So the comments for nataglinide, it should be given 30 minutes before meals, and the ripaglinide should be given also 30 minutes before the meal. And caution in hepatic and renal insufficiency, like the sulfonylurea also. We can move to the biguanide. Well, biguanide does not act like the sulfonylurea or the or the meglitinides. The biguanides, as you see here, like the metformin, all of you know knows the metformin. The metformin is one of the drugs that could increase the insulin sensitivity and decrease insulin resistance. So basically, the metformin, one of its important actions is increase insulin sensitivity and decrease insulin resistance. The metformin and the other classes, which contain the pioglitazone, it also increases the insulin sensitivity and decrease insulin resistance. The metformin does that, and also it acts in the GI to prevent the absorption of glucose, and also it has an effect inside the liver. It prevents the degradation of glucose from the liver, or the release of the glucose from the liver to the blood. So the metformin tries to minimize the blood glucose as general. So here in the biguanides, we have the metformin. Of course, all of you know that the metformin, it has a different dosage, 500 to 200 to 2,550 per day. It could be given in divided doses. And its trade name is glucophage. I guess all of you knows that, of course. The formulation, of course, you know the metformin. Here, the key important information about the metformin is we should avoid metformin in people who are elderly or more than 8 years, unless the creatinine clearance is equal or more than 60 ml per minute. What I'm trying to say that the metformin is excreted through the kidney. So any condition that associated with chronic kidney disease or renal impairment, the metformin should be used with caution. So elderly people will have like a decrease in their GFR. We have other conditions. If any other patient who have higher creatinine level due to renal impairment, like if the creatinine was more than 1.5 in men or more than 1.54 in women, we should be very careful to use metformin, because as I mentioned, it's secreted through the kidney. And of course, in heart failure, COPD, and with high liver function tests, as general, metformin could lead to the accumulation of lactic acid. So any condition that associated with anaerobic glycolysis or hypoperfusion, like heart failure, there is decrease in cardiac output, there is hypoperfusion to the tissues, anaerobic glycolysis, and accumulation, of course, of lactic acid. So heart failure is one of the conditions that we cannot use metformin without caution. And also the liver function test, if there is any liver impairment, the liver itself is responsible to remove the lactic acid. There is something called corecycle from the biochemistry, if you can remember. But if there is any liver impairment, also we should be very careful to use metformin in patients with liver diseases. So we have metformin and metformin extended release with their formulation and with their key comments, as I mentioned. People who are elderly with decreased GFR or with decreased creatinine clearance less than 60, we should be careful to use metformin, even in heart failure, COPD, liver impairment, and the conditions that associated with accumulation of lactic acid. So we can move to the next subclass of anti-hyperglycemic agents, thiazolidinidiones. Well, this category, it has something similar like the metformin. As I mentioned a few minutes ago, that I said that metformin has the ability to increase insulin sensitivity and decrease insulin resistance. This category also acts like the metformin in the term of decreasing the insulin resistance and increase insulin sensitivity. We have many drugs like pioglitazone, like rosiglitazone. So these drugs, we should be familiar with the dosage, of course, and the formulation. And also, we should know the metabolism or the comments with pioglitazone. So the pioglitazone, we should check the liver function test at baseline, then every 2 months for the first year, and then periodically. We should avoid liver disease if the liver enzymes are higher, because people who are receiving pioglitazone could have a higher risk to develop hepatotoxicity. Also, it increases fracture in women, so it has a side effect, and we should be very careful to prescribe this drug for those patients. As general, not the pioglitazone, actually the rosiglitazone Specifically, it was restricted, I guess, in 2013 due to its, before 2013, due to its severe side effects that associated with cardiovascular complications. And then the restriction was lifted in 2013, but it's used with very caution. It's not used like it has been used in the past. So they stopped using it broadly, the rosiglitazone. So we should also monitor the liver because pioglitazone also increase the risk of hepatotoxicity. And of course, it has a major side effect, which is cardiovascular risk. The rosiglitazone, in comparison with the other drugs from the same class, has a higher risk to develop cardiovascular complications. And also it increased fracture in women. It has a higher association with osteoporosis. So the FDA has significantly restricted its use. We have another category that's called alpha-glucosidase inhibitors. So from the name of the alpha-glucosidase inhibitor, I can say that, in our GI, inside the GI, we have enzymes that are responsible for the degradation of the glucose in order to absorb it. Actually, we are taking the glucose in our diet like a disaccharide or polysaccharide. We cannot absorb the glucose as a polysaccharide. We need to degrade the carbohydrate into monosaccharides in order to absorb it to the blood. So in the small intestine, particularly in the villi of the small intestine, we have an enzyme that's called alpha-glucosidase. This enzyme responsible of degrading the glucose, particularly the disaccharide. The polysaccharide, when enters through the GI, we have the amylase that produced by the salivary glands, and then the amylase that produced by the pancreas, and all the physiology of the GIT. And then it will be degraded into smaller parts like oligosaccharides and disaccharides. We need the alpha-glucosidase to degrade this glucose more and more to make the monosaccharides of the glucose in order to make it easier to absorb. So there is drugs that act as alpha-glucosidase inhibitors. That means it will inhibit this enzyme, and that means the glucose inside the GIT will not be absorbed. That means we will decrease the absorption of glucose, and this of course will lead to decrease the glucose level in the blood. But on the other hand, I can say that the glucose inside the GI, it will reach to the colon or to the large intestine, and we have bacteria in the large intestine, so it can ferment the glucose. And also the glucose inside the GIT, it will increase the osmotic pressure, so it will increase the or pull the glucose from the, it will pull the water from the blood vessels to the lumen. So what I'm trying to say that it has a really side effect associated with the GI. Maybe I forgot to say that, but the metformin also, because it prevents the absorption of glucose from the GI tract, it's also associated with the GI. I don't know why I forget that, but one of the important and significant risk factors of the metformin is GI disturbance. It acts in similar way, not the exact mechanism of action, but the similar pathway, like preventing glucose absorption. So it can lead to GI disturbance and diarrhea, flatulence, and all these things. So the alpha-glucosidase inhibitors like acarbose and miglitol, with their dosage, with their formulation, the effect, the commentary is very important that acarbose is associated with the GI effects. This is commonest. And of course, because the excretion through the kidney, we should be careful to use it in people with chronic kidney disease or renal impairment, particularly if the creatinine was with more than 2 milligrams per deciliter. And also we need to monitor the liver function test. And with miglitol, similar to carbose, but we don't need to monitor the liver function test. So I can go here to the DPP-4 enzyme inhibitors. What I'm trying to say here is that we have also a category of drug that acts in the enzyme called DPP, dipeptidase 4 enzyme. So, when we are taking glucose orally, the glucose will enter the GI system. It will enter the small intestine, and then this glucose will activate hormones that will be secreted by the GI itself. So what I'm trying to say is that we have the pancreas and we have the GI, of course. When glucose enters through the oral route, through the GI, the glucose inside the stomach and mainly inside the small intestine, it will activate the release of hormones, I can say hormones, that's called incretins. This incretins is very crucial. When it's secreted from the small intestine, it will activate the pancreas to produce more insulin. And that is very effective because when we are taking oral glucose, this will lead to activation of the pancreas directly through the incretins, and it will lead to the production of insulin. That's why when we are taking oral glucose, if you are a normal person, when you are taking an oral glucose, that means the incretins will be secreted and it will act on the pancreas and it will lead to the secretion of insulin. So your blood glucose will be controlled, subhanAllah, rapidly. In contrast, when you are taking glucose through the IV, if you are taking glucose IV, the pancreas will not produce a sufficient amount of insulin. This effect, subhanAllah, produced mainly by the GI through the incretins, okay? So the incretins will, like the glucagon-like peptide 1, this hormone, is these incretins will be degraded by the enzyme, the dipeptidase enzyme 4. These incretins will be degraded by this enzyme. So if we are giving a drug that inhibits this enzyme, that means the incretins like glucagon-like peptide 1 will be secreted more and more, and this will lead to the activation of the pancreas to secrete insulin, and this will lead to the good control of hyperglycemia. So we have the saxagliptin, we have the sitagliptin, we have vildagliptin, we have a variety of drugs in the category of DPP4 enzyme inhibitors. So the saxagliptin, we should, of course, with its dosage and formulation, the most important thing that we need to adjust the dose in renal impairment due to the excretion, on also sitagliptin, which is used alone or with metformin or other drugs. But here, the most important thing that the first one, we need to adjust the renal dose if there is renal impairment. So this type of drug, we come up to the sodium glucose co-transporter 2 inhibitors. This type of drug is very important. This category is really very important. I guess it's considered to be a newer category. It acts on the sodium glucose transporter 2. What I'm trying to say here is that, you know, inside the kidney, we have the functional unit, which is the nephron. And in the nephron, we have proximal convoluted tubules, descending lobe of Henle, the distal convoluted tubules, the collecting duct, and all of you knows that, of course. In the proximal convoluted tubules, well, you know, this is the glomerular line. It will filtrate the glucose and the amino acid and the bicarb and all these things. But the glucose should be absorbed, like the glucose and proteins, I mean, the glucose and amino acid should be absorbed 100% in the proximal convoluted tubules. So we have transporters to absorb this glucose. So if we have hyperglycemia, that means we have a lot of glucose here in the proximal. There is a lot of glucose that will be filtered in the proximal convoluted tubules. And because it's very high, the transporters will try to absorb all the glucose that have been filtered through the glomeruli. So if we try to block the reabsorption of the glucose through the sodium glucose transporter 2, we will lead to decrease the absorption of glucose, and of course it will help also in the reduction of blood glucose level, because we are giving the glucose the opportunity to descend in the urine. So particularly these drugs, the sodium glucose transporter 2 inhibitors, it prevents the absorption of glucose in the proximal convoluted tubules. That means the glucose will be excreted in the urine. These drugs like empagliflozin, dapagliflozin, and canagliflozin, with their typical dosage and their formulation. Well, you know, these drugs are very nice because they have found that these drugs, after extensive researchers in this area, they have found that these drugs have a very good impact or a very good positive prognosis in patients with heart failure, even without diabetes mellitus. So these drugs, particularly the empagliflozin, these drugs have a very good impact on cardiovascular complications, particularly in the heart failure. So the metabolism, it's minimally, the empagliflozin minimally metabolized. Most of the drug is excreted unchanged. The dapagliflozin metabolized in the liver through the glucuronidation, and the canagliflozin metabolized in the liver and also excreted by the kidneys. And these drugs also could affect, in diabetes mellitus, it has a renal protection effect also. So, you know, we have gone through the different or the variety of oral hypoglycemic agents, non-insulin agents. So there is a category that's called combination oral non-insulin agents. You know, when we are trying to combine more than one drug of the diabetes or of the oral hypoglycemic agents, this could help in many ways. When I'm trying to say, if we combine two types of drugs with different mechanism of actions, that means we will have one tablet contains two drugs with different mechanism of actions, and this will help us to reduce the pill burden and increase compliance, particularly in elderly patients. And also because there is a different pathophysiological mechanism, giving two drugs with different mechanism of action that would be beneficial to decrease the hyperglycemia. And of course, to simplify the regimen, particularly for elderly or polypharmacy patients. So we have here a combination of drugs. Like here you can find the glipizide, metformin. We have gilbiride, metformin, biglitazone, and metformin, ribaglinide, and metformin. We have come across the metformin. It's a part of the piguanides, and the glipizide, sulfonylureas, desulfonylureas, biglitazone, ribaglinide, miglitinide. So we come across that with their trade names, with their dosage and formulation. So in the glipizide and metformin, we have keynotes that we should avoid it in elderly people who are more than 80 years old. You know, glipizide and metformin, of course, they are secreted renally. So if there is any renal impairment or elderly people as general, they will have a decrease in their GFR. So elderly people or people who have chronic kidney disease or renal impairments and so on. So this is the most important part here. But yes, having a multiple combination of oral hypoglycemic agents will be beneficial, as I mentioned. And also here we have the combination of rosiglitazone with glimepiride, rosiglitazone with metformin, biglitazone with glimepiride, sitagliptin with metformin. All these drugs are very beneficial, but also it has like notes that rosiglitazone and metformin, of course, also we need to avoid it in elderly people with renal impairment. But it's very beneficial to take two drugs with different mechanism of actions and with better compliance in elderly people with their, of course, dosage range and formulations. Now we can come to the injectable non-insulin agents for treating diabetes. You know, the injectable agents, all of you know that the injectable agents are insulin and its subtypes, but we have other drugs that considered to be injectable, but it's not insulin. So we have here drugs called exenatide and its other drug in their category. What I'm trying to say here is that the exenatide and the bramlintide, both of these drugs used subcutaneously to decrease the blood glucose. But you know, the exenatide and its brother, the keynote that it's incretin mimetic. Do you remember when I said that the incretins are hormones produced by the GI to increase the secretion of insulin from the pancreas? So the exenatide, it's an incretin mimetic. It acts like the glucagon-like peptide 1, which is a hormone or an incretin hormone. So it decreases the hemoglobin A1C by 0.4 to 0.9%. One of its side effects, nausea, hypoglycemia, which is common, and less weight gain. Actually, these drugs lead to reduction in weight. Because, you know, the drugs that will increase the insulin, it will lead to weight gain, like insulin itself, the sulfonylureas, the miglitinides. Each drug that will increase the insulin secretion, because insulin is an anabolic hormone, it will increase the weight. But here, exenatide, yes, it acts like the incretins, it increases insulin secretion, but it has another effect. It acts in the hypothalamus to decrease the appetite. So it's nowadays, it's used to decrease weight. Not as evidence-based medicine, but I'm saying that it's a subcutaneous injection used to decrease hyperglycemia, but some people use it right now to decrease their weight. So it acts like incretin analog. And of course, we should avoid it if the creatinine clearance was very low, less than 30 ml per minute. And the other drug also, it acts like amylin analog, and also it will decrease the hemoglobin A1C by 0.4 to 0.7. It also has a side effect like nausea, vomiting, hypoglycemia, and common reduced pre-meal short-acting insulin by 50%. And now we can move to the insulin preparations for the treatment of diabetes. You know, all of you knows that the diabetes mellitus, one of the treatment categories is insulin itself. Well, in type 2 diabetes mellitus, we can start with the oral hypoglycemic agents because it increased the insulin sensitivity, which is the main issue in type 2 diabetes mellitus. But if we started these medications and there was no control, or if patients with diabetes mellitus have a specific status or resistance to the previous drugs, we can start to use the insulin. So the insulin itself, we have different types of insulin. I can say that we have the rapid-acting insulin, we have regular or short-acting insulin, we have the mixed-start insulin, we have the long-acting insulin. You know, the rapid-acting insulin, like the aspart, lispro, and glulisine, these drugs could be used in combination with basal insulin like glargine to control diabetes mellitus, because it will be very close to the physiology of our body, subhanAllah. In our body, we have a basal insulin that's secreted by the pancreas. And when we start to eat a meal, after each meal, the pancreas will start to secrete insulin, because the meals that contain carbohydrates will lead to the secretion of incretins from the small intestine, and this will activate the pancreas to produce the insulin. So, subhanAllah, after each meal, our pancreas will have a surge of insulin secretion in the blood to decrease the postprandial hyperglycemia. So we have the aspart, lispro, glulisine. All of these drugs are, or all of these formulation of insulin considered to be rapid acting. It acts very rapidly. The onset of it could be from 15 to 30 minutes or even less than 15 minutes, but I can say that from 15 to 30 minutes, and the peak is at the first 1.5 hours. If you can see here, the lispro and the aspart and the glulisine, and it can last up to 4 hours, as you see here. And we have the regular insulin or the short-acting insulin. Also, the onset of this drug, the regular one, the onset is from half an hour to an hour, and the peak within 2 to 3 hours, and it can last to up to 8 hours. The regular insulin, the short acting insulin or the soluble insulin, you know that it's just used in as a monotherapy. It will be used in DKA, but we can combine it maybe with intermediate insulin to be prescribed for patients. And we have the neutral glutamine hagedorn, which is intermediate insulin. So the onset of the drug will be 1 hour to 1.5 hours, and the peak between 4 to 12 hours, and it could stay to several hours. And of course, the long one, like the ditimer and the glargine, will stay for a longer period, maybe 24 hours. It's considered to be prescribed for as a basal insulin, and you can combine it with the rapid acting insulin if you want to mimic the physiology of the body. These the drugs I have already mentioned: the rapid acting, regular insulin, okay, and the intermediate and long acting. Also, I've mentioned the timing of each one with their trade name. Okay, now we can move to the education and self-management support. So patients with diabetes mellitus, the management, we need to refer to a diabetes educator, disease management program, or specialty physician care if the patient is clinically complex. And of course, annual diabetes self-management training is covered under Medicare Part B. It's a type of health insurance in USA. Involve and educate a caregiver if the patient is cognitively impaired, because people who are cognitively impaired, you need to educate, of course, the caregiver to decrease the complications of the diabetes. Significantly disabled or frail or has limited proficiency in English, we need to educate their caregiver. Educational and self-management support, we should recognize and manage hypo and hyperglycemia in patients with diabetes, and we should monitor blood glucose when appropriate, of course, follow diet and physical activity guidance, understand medications and side effects, and practice proper food care, as we mentioned earlier. So as a summary for, diabetes mellitus management, so diabetes and impaired glucose tolerance are essential to identify and manage, especially in older adults. And due to the heterogeneity in older population, diabetes treatment goals must be individualized. What I have said in the beginning of this topic, I said that people who are elderly with many comorbidities and frail, our target or our priority not to make a tight restrict of hyperglycemia. In order, we are trying to control the risk factors and improve the quality of life to increase their life quality. And in young adults or in young old adults, what I'm trying to say is that the people who have a functional status, a strong functional status, they don't have many comorbidities or other conditions. We can hear the priority here could be to make a strict hyperglycemia control, because they can get benefit from this strict hyperglycemia control. And the blood pressure control is important in older diabetic patients and should be lowered as tolerated. You know, the blood pressure itself, in the beginning of the lecture, I can say something. I remembered it now. Is that subhanallah, they have found that the microvascular complications that occur with diabetes mellitus, if we need to decrease the microvascular complications, we need the intervention or the treatment to be given for like 8 years or more to have a significant impact in the microvascular complications. But if we start to control like the hyperlipidemia, the blood pressure, that would be very beneficial, and it can have a significant impact in decreasing the complication of diabetes mellitus within shorter period, like 2 to 3 years. So the life expectancy of the patient is very important to help you to specify a certain type of management. So diabetes self-management plays a key role in care and is supported by annual training covered under Medicare Part B, as you have seen. So I have come to the end of my presentation in the management of diabetes mellitus, particularly type 2. Well, we have like 3 cases. We are trying to go over these 3 cases quickly and to see if we can answer the questions together. So the first case says that an 82-year-old man living in a nursing facility is evaluated because of a gradual functional decline. A gradual functional decline. He has lost 4.5 kilograms. So he is an elderly patient in nursing facility with gradual functional decline. He has lost 4.5 kilograms since entering the nursing facility 6 months ago, following hospitalization for acute myocardial infarction. Well, he had an acute myocardial infarction, and then he started to lose his weight, and now he has gradual functional decline, which is an important thing here. And they said that during that hospitalization, type 2 diabetes was diagnosed. So he has been diagnosed with type 2 diabetes mellitus after having the myocardial infarction, and then and then he started to develop a decrease in his functional status. Then they said that in the nursing home, he has remained hyperglycemic. So he has hyperglycemia with periodic blood glucose concentration spiking up to 300 milligram per deciliter. That means it's high. The patient started to develop hyperglycemia. And a recent hemoglobin A1C level of 7.5%. Well, in this clinical scenario for this elderly patient with other comorbidities, many clinical trials demonstrated that the control of hyperglycemia in elderly patients who are elderly, like more than 80 years old with other comorbidities, the strict hyperglycemia will not be beneficial. It will be, in the contrast, it could be harmful for them. So controlling the blood glucose or controlling the hemoglobin A1C to be less than 8% is considered to be very good. So 7.5, it's considered to be very good for this elderly patient with other comorbidities. The patient follows an American Diabetes Association low diet. So we can see that he is following American Diabetes Association low-fat diet and is on several medications, including glipizide, sulfonylurea, pravastatin, which is statin, hydrochlorothiazide, diuretics, metoprolol, beta blockers, lisinopril, ACE inhibitors, and aspirin. The laboratory results shows that the creatinine is 1.4, which is slightly increased, or it increased, and the LDL is 100. Well, it's a little bit increased, and the HDL is 34, which is considered to be decreased, and the triglyceride also a slightly increased. It's more than 150 milligram per deciliter. So in this patient, we have dyslipidemia or hyperlipidemia, okay? And he is elderly, fragile in the nursing facility. He started to lose weight. So after losing weight, after having myocardial infarction, and they discovered that he had diabetes mellitus and hyperglycemia. He has hyperglycemia, but with gradual functional decline in his status. So what is the question? The question says that, let me just do this. Which of the following is the most appropriate next step in management of this patient? Do we need to increase the glipizide dosage or add metformin? Well, I can remember that at the beginning I said glipizide and metformin, both of them are excreted renally. So this patient with creatinine level 1.4, it's considered to be high. So increasing glipizide in this patient or adding metformin, it could lead to a harmful effect rather than a beneficial effect. So, of course, giving glipizide or metformin will not be a good idea for this patient who have decrease in their weight due to restricted diet, and also he has episodes of hyperglycemia, but their hemoglobin A1C is 7.5, which is good for his status. We need it to be less than 8%. So add acarbose. I said that acarbose acts in the GI and it has many side effects, so it does not have a real effect. So add niacin for this patient. Does it have a good effect? Well, it's a good thinking, as said Dr. Reem. Add niacin. Niacin could control the hyperglycemia, but you know, the patient has decreased, his weight is decreased dramatically, as you see here, and he is on American Diet Association low fat, Diabetes Association low fat diet, and his weight loss is significant, and this could be the cause of his decreased functional status. So the best answer for this patient is to start to liberalize his diet to decrease the restriction of his diet. So this patient is elderly, frail, he has multiple comorbidities, and he is experiencing actually a weight loss. So the priority in this patient is to maintain nutrition and quality of life rather than just tight glucose control. So liberalizing the diet will help to improve his caloric intake and will help to increase his functional status. But it's a good thinking to think about niacin. Niacin, it will affect mainly the triglyceride, but it has no effect on their quality of life for this patient. So the most likely answer here will be liberalize his diet, but very good thinking. We can move to the next case, which says a 72-year-old man comes to the office for evaluation because he has impaired fasting glucose levels. Fasting glucose levels have ranged between 110 and 120 milligram per deciliter on 3 separate occasions. In this context, I could say that the fasting blood glucose is high. So he has well-controlled hypertension, alhamdulillah. His body mass index is 29.5, which is considered to be high. So the question says, which of the following is the most likely to prevent the development of type 2 diabetes mellitus in this patient? This patient with a slight increase in the fasting blood glucose is considered to be in the pre-diabetes area, and he is 72 years old. He has hypertension, and his body mass index is considered to be high, 29.5. So if you want to control this condition and to prevent the development of type 2 diabetes mellitus, we need to do an intervention. So the first line that we could do, or we could intervene to prevent the development of pre-diabetes to diabetes mellitus in this patient, is with reduced caloric intake and increased physical activity to 150 minutes per week, or increase physical activity and begin metformin. Actually, metformin, it's not considered to be a first line at all. First line is, okay, someone answered, and it could be excellent. Dr. Muhammad said that we should start with reduced caloric intake because he has already, he is overweight, right? His body mass index is higher. So reducing reduced caloric intake and increased physical activity, this combination is very beneficial as a first line to prevent the development of diabetes mellitus from pre-diabetes. So increase physical activity and begin metformin. As I mentioned, metformin is not considered to be the first line. Begin metformin only, still it's not the first line. Reduced caloric intake could have an effect, but actually it's not beneficial unless it's combined with the exercise. So as said, Dr. Muhammad, A is considered the best answer in this question. Excellent, very good. So moving to the last case says that An 81-year-old woman is brought to the office by her daughter, with whom she has been living since the recent death of her husband. She is a former smoker and drinks socially. Her medical history includes osteoarthritis of the hip and knees, hypertension and incontinence, a lot of comorbidities, which has recently worsened and limits her willingness to leave home. Well, that's a bad statement. She had a stroke several years ago that left her with some right-sided weakness for which she uses a cane. Okay. Her current medications include ibuprofen, glucosamine, hydrochlorothiazide, aspirin, multivitamin, and fluoxetine, started after her husband's death. So she's elderly female with many comorbidities and a history of stroke. We can continue. Her weight is 90.7 kilogram and her height is 1.65 meters. Of course, from her height and weight, you can see that her body mass index is high. The blood pressure is, okay, good, 126/78, and her pulse is 70 beats per minute and regular. Physical examination reveals a left carotid bruit, slight weakness and rigidity in the right arm and leg with associated gait abnormality and bilaterally decreased dorsalis peris and posterior tibial pulses. Both feet have slight edema. So this patient had a history of stroke. She is elderly with many comorbidities and peripheral vascular diseases. There is a lot of comorbidities. She has left carotid bruit. That means there is a stenosis in the left carotid that maybe lead to her stroke itself. Maybe the atherosclerosis will lead, of course, to the formation of thrombus and then detachment and then go to the cerebral arteries and lead to stroke. So this patient has a lot of comorbidities. She scores 29 out of 30 on the mini mental state examination and 11 out of 15 on the geriatric depression scale. Okay. So the laboratory results, which is very important, the fasting blood glucose is very high, as you can see here, 165, that's very high. Hemoglobin A1C, 7.5, okay. Total cholesterol, 215, it's high. HDL 35, low. LDL is 140, considered to be high. Triglyceride, more than 150 milligram high. Potassium in the upper limit. Creatinine is increased. Repeat fasting glucose 2 days later, which is still high. So this patient has very high fasting blood sugar. She has high lipid profile. She has hyperlipidemia, okay, and hypertriglyceridemia. And hypercholesterolemia, both of them, so she has hyperlipidemia, of course. And urine analysis positive for microalbuminuria. That means her diabetes mellitus started to cause nephropathy. So this patient has many comorbidities like the stroke, the hyperlipidemia, her fasting blood glucose is very high, and she has peripheral arterial disease and all these things. So what is the question here? The question says, which of the following medication is most likely to decrease this patient's cardiovascular risk? This patient has a very high cardiovascular risk complications due to her conditions and comorbidities. So which of these drugs considered to be very effective and very strong based on the evidence-based medicine to decrease the cardiovascular risk? Is it glipizide or metformin or valsartan or simvastatin? We can say glipizide and metformin have no significant impact on cardiovascular protection or cardiovascular risk reduction. Okay, people, excellent, very good. Dr. Maram said that simvastatin, that's true, excellent. So the valsartan and simvastatin, the valsartan belongs actually to the ARBs, angiotensin receptor blockers. So the angiotensin receptor blockers have a good effect on cardiovascular conditions, particularly in the heart failure. It decreases the remodeling like the ACE inhibitors, with the same mechanism of action. But this patient with her comorbidities and hyperlipidemia, the drug that is more effective and it has a very strong evidence-based medicine to decrease the cardiovascular complications, this patient is simvastatin. So both of these drugs have an effect on the cardiovascular complications. Both of them could reduce the cardiovascular complications, but the simvastatin has the strongest evidence-based medicine to decrease the cardiovascular complications in patients with diabetes and other comorbidities like severe hyperlipidemia. So here the most likely answer is simvastatin, as Dr. Maram said. Excellent, very good. So the answers for case 1, liberalize his diet. Case 2, reduce caloric intake and increase physical activity to 150 minutes per week. And case 3 answer is simvastatin. Now we come up to the end of our presentation. I hope that it was beneficial for you. Thank you so much for listening to me for too long. If you have any comment, anything you want to say, you are free. Thank you so much, everyone.
Hello, Nadir.
Hello, go ahead,
everybody.
Dr. Ahmed. Go ahead.
Yes. Thank you, Dr. Ryan, and your colleague who talked before you. This is really nice presentation, comprehensive. You covered diabetes and the management. You talk about also the different medication, and diabetes is one of the commonest problem, and we should know about it and its management. Also, it is the most common secondary cause of renal failure. So we have really to pay a very close attention, and also prevention is a key. You talk about the management and the medications, and especially SGLT2 inhibitors. And this is very good medications for diabetes, and also it will reduce the blood pressure. It has advantage in preventing heart failure, and also has a positive effect on chronic kidney disease. And so that is really very beneficial. Side effects include urinary tract infection, because it will reduce the absorption of glucose. So the presence of glucose kind of risk factors for urinary tract infection, especially yeast. We have to know about that.
Thank you for adding that.
And you mentioned, you covered very well the other side effects as well. Other medications, you mentioned it, and also the insulin. Be sure that, like, sometimes when we have patients with a very elevated hemoglobin A1C, sometimes we might need to shift our patient to long-acting insulin, and we talked about that, especially Lantus, and that could reduce hemoglobin A1C, and then you will follow your patient and you might change to oral hypoglycemic agents. And the other thing is that patients with diabetes, when they come for follow-up, you check for proteinuria, especially the albumin, and S or ARB are the medications that will reduce the protein in the urine. Presence of protein in the urine and makes us think of nephropathy, and so in the follow-up we will do that. The simple thing we can do is random urine albumin creatinine ratio, and sometimes we do random urine protein creatinine ratio, and this is found is as accurate as 24-hour urine collection. Sometimes collection of urine is a torture. We can use the random urine samples, and it will give us a very good estimation. And this is about, yes, the other thing is that people with diabetes and the cases you mentioned are very good examples, and really with comorbidities. So we see like increased BMI, hyperlipidemia. Sometimes they have coronary artery disease and also chronic kidney disease. Those who have coronary artery disease, stent placement, and here you are talking about the secondary prevention, and you put people on anti-hyperlipidemic agents. And looking at the cholesterol panel, you are looking at total cholesterol, HDL, LDL, and don't forget to look at lipoprotein A2, which is categorize your patient. If it is more than 75 milligram per and more than 75 nanogram per liter, this is kind of a risk factors, and then it is mandatory that you will continue on treatment, and also you'll be meticulous, and you could add more. So what are the target level for LDL? Usually diabetes is a risk factors. You target about 70 milligram per deciliter of LDL. But if the patient has coronary artery disease, has a stent, CABG, then you will target at 55 milligram per deciliter. This is LDL. So pay please close attention to the lipid panel and the target level. So looking to go back to the protein in the urine, you will also look at the blood pressure. The blood pressure will be in proteinuria 130/80 milligram per deciliter. This is also important. Talking about the blood pressure, also think about other comorbidities. And just let us talk about the patient you mentioned has increased BMI. So for questioning, is this patient has obstructive sleep apnea? Also, this is important because with obstructive sleep apnea, people have hypertension. And when you look at the daytime and nighttime blood pressure, with those who have chronic obstructive sleep apnea, the nighttime blood pressure is relatively high because the daytime blood pressure and the nighttime blood pressure, there should be a difference. Normally, they will be a 10% lower. The nighttime blood pressure is 10% lower than that of the daytime blood pressure. And we call this dipping. The reason I mention it with people with obstructive sleep apnea, the dipping will be less. And this leads to cardiomegaly, cardiac disease, and it needs to be treated, because if you treat obstructive sleep apnea, you will reduce the diastolic blood pressure by 2 to 3 millimeter mercury, and also the systolic blood pressure by approximately 5 millimeter mercury. And this is not small, especially when someone is sleeping, and it makes a difference. And it is found that this is also good for survival, living longer. So in your patient, screen for obstructive sleep apnea. And really, we extract these things just by the case you share with us. And really, they are very, very good cases. And we can talk more about these cases as well. And so this is about hyperlipidemia. We talked about that, the blood pressure, the proteinuria, and also your patients will see ophthalmology, because if they have protein in the urine, likely they might have high manifestation of or retinopathy. They could. This is one thing. These days, looking at, and you mentioned like the medication, you talk about the pharmacokinetics and dynamics. Also, with the new things, look at the third dimension. Some of the medications might be like genetically not suitable for some patient, and this is the third dimension we are looking for in using any medication, which is pharmacogenetics or genomics. And this is when we talk broadly about every medications. But it is really nice presentation. Thank you so much for sharing these cases. And also the first presenter also did a nice thing. So you mentioned type 1 and type 2. And one thing about SLGT2 inhibitors, they use for type 2 diabetes, not type 1. Okay.
Thank you so much.
Thank you.
Ahmed.
I hope I'm not using more time, and thank you.
Thank you so
Thank
much,
you.
Dr.
Thank you for your great presentation, both of you. Go ahead.
Yeah,
just
thank
like-
you. I'm done.
Okay. I wanted to say thank you, Dr. Nader. Thank you, Dr. Ahmed, for your valuable information. I guess it's very helpful for us, and we have added new information from your talk right now. So thank you, everyone, and thank you for your kind words. I guess Dr. Hiam will continue to moderate the meeting for the next presentation, inshallah.
Thank you very much for nice presentation, Dr. Yaqeen and Dr. Rayan. The second topic we are talking about with data collective, and that's will begin by Dr. Maram, then Dr. Dr. Maram, are you ready? Hello, Dr. Maram?
Yeah, ready.
Yeah, okay. You can share your screen.
Okay. Hello, everyone, and welcome to our third part of today's meeting. My name is Maram Abdurrahman, and my colleague, Dr. Amna Al-Haj, and I will be presenting this session under the title Understanding Data and Variables in Clinical Research. So can you see my screen clearly, or?
Yeah, it's
Okay.
not clear. Yeah, now it's clear.
What about now? Okay.
Yeah.
That's good. Before we start, I'd like to congratulate actually Dr. Mayra. Thank you for sharing your tips, and I wish you a very happy and enriching residency experience. I'd also like to thank Dr. Rayan and Dr. Yaqeen. Your presentation and hard work really shine through in this session, so thank you. Well, now we can start. Our topic today covers one of the basic concepts in the world of research: understanding data and variables in clinical research. And I believe everyone here is familiar with it. So our aim is just to refresh your memory. Okay, our learning objectives are, first, to distinguish between the types of data used in clinical research, to differentiate between qualitative and quantitative data types. Right after that, we are going to jump into variables. We will define them, identify dependent, independent, and confounding variables. Back to data, we are going to understand primary and secondary data sources. We will also learn how to apply appropriate data collection techniques in clinical settings. And last but not least, we are going to talk on how to ensure good quality of your data. So the definition of data is systematic observations or measurements collected for analysis. The purpose of data collection can be to evaluate a hypothesis if we are working in a research work, to monitor patient outcomes. You can also collect data to support clinical decision-making. Examples for data are sex, age, weight, marital status, and satisfaction rate. So what are the types of data? Data generally is divided into two major types: qualitative data, we also call them categorical data, and quantitative data or numerical data. The qualitative data is non-numerical data. Examples for them are gender, blood type, and disease category, as for diseased and non-diseased. For the quantitative data or the numerical data, it's a measurable data, numerical data that has units. Examples for them are age, BMI, and lab results. The numerical data is further subdivided into two types: the continuous data and the discrete data. The main difference between the two is the continuous data can use decimal numbers, while the discrete data only use whole numbers. The continuous data, measured data can have an infinite values within a possible range. For example, if you want to measure the length and weight of this cutie here, we can use decimals. As for the discrete data, we can use only whole numbers, observations that can only exist at limited values and often count. So, for example, this octopus here has 8 legs and 4 spots. Another example for this is the number of patients. We can't say we have 5.5 patients, for example. We use only whole numbers to count them. So the discrete data is counted. With continuous, can use an infinite values. As for the categorical data, is further subdivided into, we can say, 2 or 3 types. The major difference between those types is the order. If the order is significant, then it's an ordinal data. If the order is not significant, then it's nominal. If we have only 2 options, then it's finite data. After knowing the different parts of data, now we are going to move to variables. Variables are characteristics measured or observed in a study. For example, if we have a study that measures the effect of exercise on lowering cholesterol, the exercise and the cholesterol, those are the 2 variables that we measure in this study. The variables help answer the research question. We have different types of variables: independent, dependent, and confounding variables. The 2 major types, of course, are the independent and dependent. The independent variable is the one that we manipulate or change in order to observe its effect on the dependent variable. An example for that is a drug dosage in a study where we measure the effect of changing the drug dosage on the blood pressure level, for example. The dependent variables is the outcome that we measure. And in this very same example will be the reduction in blood pressure. As for the confounding variables, those are the variables that distort the true relationship between our variables that we measure in a study. In this example, the confounding variable can be the age or the smoking status. So just to make sure that this concept is clear, the difference between dependent and independent variables are the independent is the one that we apply to see the effect in the dependent. The dependent variable is dependent over or on the other variable. It's the variable that is measured or tested by a researcher. So the independent variable have an effect or make a change in the dependent variable. The confounding variables. The confounding variable, as we said, it distorts the relationship between the variables, and it can result in bias. An example for that, in the study that we mentioned earlier, a study on exercise and cholesterol level, the confounding variable can be diet. And we want to make sure to reduce the possibility of having a confounding variable as much as you can to avoid confounding bias. So things that can help us reduce that are randomization, stratification, and regression. And due to the limited time that we have, we won't dive deep into those, but I hope that one time in the future, we can cover it through our meetings. Okay, now we are moving to ensuring data quality. And Dr. Amna will continue from here, inshallah. Thank you.
Hello, everyone. Can you hear me?
Yeah, we can hear you.
Okay.
Yeah.
My name is Dr. Amna Qasim, graduate of University of Khartoum, Faculty of Medicine. I'm so happy to be here with everyone. I would like to congratulate Dr. Myra, and hopefully all of us can share our stories next year. Okay. Let's continue our presentation. Ensuring data quality. Okay. How can we make sure that the data used in our research project is of good quality? We have a couple of tips we'd like to share. First of all, to use a standardized collection tool and process, or we can also standardize using the SOP, which is the standard operating procedure, which means when we use a standardized questionnaire or any collection tool, we can make sure that the methodology is consistent across all the data collector. We can make sure as well that we follow all of our team is following the guideline, which are the SOPs. They are if it's the first time you hear about it, they are a written guideline that ensure that everyone will follow the same step regarding the data collection. That will reduce the variability and error, and it will also ensure that the data are reliable and comparable. We can also do train the data collector or training all the data collector as a step before the data collection start. The training will help us again to ensure that everyone is familiar with the data collection tool, and everyone will use the same. We can say the same terminology, especially if we're using, for example, we can use a different language other than the original language of the questionnaire, if it was translated and so on. So we need to make sure that everyone is using the same phrases. Okay, so training will ensure that everyone will understand the same question and will ask in the same manner to help us avoid the mistakes and reduce the biases. And we at the end, the goal is to have a uniform data entry. Third step, we can do piloting. What do you mean about piloting or pilot testing? It's just a pre-testing for our data collection tool. It will involve just testing the data collection tool and the process in a smaller scale. So we'll just, for example, we'll take a small percentage of our sample. Let's say if we have if our sample size is 300 patients, we can pre-test the questionnaire on 10% of them. Let's say a 30 patients. We'll do the whole process. We'll ask them through our questionnaire or whatever data tool we are using, and we'll analyze the result. And that's what in that way we can pre-test the questionnaire, make sure that we reduce any error either from the data collection process or the questionnaire itself. So this is what that will mean about piloting. So we can identify issues. If you have any confusing question, for example, technical problem, logistical challenges, prior to the data collection period. We can also monitor our research project using clinical audit. If we are using a clinical audit, as you know, audits goes through cycle. So whenever you finish a cycle, you'll go and you'll test your results. So you can apply the result you found in the next cycle and make sure to reduce the error. We can also use the electronic data capture system, like the REDCap and ODK. So they can improve that. They can help to improve the accuracy, to reduce the data entry time, and to minimize the error. Okay, we can go to the next slide. Okay, here we have a couple of commonly used data collection tools. First, we have questionnaires or surveys. They're the most famous and easily used ones, especially for fresh graduates or students. Questionnaires usually have standardized versions. Again, when you use the standardized forms, it will be much easier for interpretation and analysis. The process will go more smoother, and it will be easier for the data collector to understand it. So we have the questionnaires. We can use a standardized questionnaire, pre-tested question, or we can form our own question. The questionnaire will usually have multiple choices or close-ended question, or for example, the rating scales, or they can have an open-ended question, mixed close and open-ended question. It's useful to collect the data from the large population as well, like the surveys. And we can also use the questionnaire electronically or online, or using online form like Google Form and so on. We have also apps that can apply the questionnaire inside it. Okay, like couple collect here. So questionnaire is very easy. Secondly, we have the interviews. Interviews is usually better for the qualitative methodology. If we have qualitative research, you usually would like to hear about opinions or want to share an extended form of answer, open-ended questions. Interviews will be much better. So you can share personal experiences. You can ask about perception of people for certain diseases or ask about their understanding of any topic regarding medical application. Checklist, it's simple, structured too, or just either it's there or not there. You can use it, for example, to check for, let's say, the efficacy of operation room, check for the devices, to check for anything that, if it can affect the procedure, and you can just check it if it's there or not inside any hospital. We also have the focus group discussion. It's similar to the interview, just instead of asking one person, you'll just have a group discussion. It's usually range from 7 to 10 persons, and you'll have a moderator, and you ask them the question, and you will not interfere when they answer. No prejudice, you just hear what they have, you record the session, and then we can adjust the data. It's definitely the qualitative researchers have their own methodology of analysis. It's very different from the quantitative data. We have also the observational method. We can just use the chart review. It's just to review any existing clinical record, basically mean that. It's very effective in respective cohort studies, for example. Also, I have the electronic health records. It's a digital system. You can just you will have the patient data. For example, we have the blood pressure reading, any lab results. You can use this information in your research. The wearable, like the Fitbit and the glucose monitor, they will the patient, from their name, the patient will be using them, and it will just automatically collect all the physiological data, like the heart rate, the steps, the blood glucose level, and then you can use these data as well. We have the summary sheet and checklist for record and reports. It's just used to organize and extract the data from multiple resources. Okay, let's go to the next slide. Okay. Yeah, we'll just go with the brief details on the questionnaire because it's the widely used data collection tool. In questionnaire, we have two types of question, as I mentioned. We have the open-ended question or the closed-ended question. Closed-ended question, we mean that it has a previous set of answers already. For example, you can ask them about, let's say, do you agree to the consent question? You can ask them, do you agree to fill this questionnaire or not? The answer will be just yes or no, or the scales question, or any form of question that contain choices. That basically means close and ended question because you already provide them with the choices or the answer you anticipate. The open-ended question is different. We'll just ask them a question and they will answer. Whether it's a short answer or a long answer, it's kind of different, and you can use these kind of questions inside the questionnaire. We also have two types of questionnaire regarding the type of question, whether it's structured or unstructured. Structured, we mean the standard. It will have a defined set of questions, and can also be standardized, already pre-tested, compiled, and so on. Unstructured questionnaire, you'll have the part of the question will already be with you, and you can add question from you and your team as well. We also have the last type, which it could be the questionnaire. It can be self-administered or interview-based. In interview-based, you'll ask the patient or participant. You'll ask him the question, and you will fill out the questionnaire yourself. In the self-administered, you'll hand them the questionnaire, or it's like online form. They will be in charge of filling the question. Okay, let's go to the next slide. Okay. Okay, here we have some tips for the data collection. If you're using, if it's either a self-administered or interview-based, based on our own experiences, we hope you find it useful. So let's just go through them. Try to make the answer, the questions clear and easy to fill out. Avoid difficult questions. Don't make the questions harder just because you want to make the question look cooler. No, use easy questions that can be understood in only one way. Avoid confusing questions. Of course, you have to use a correct construction, grammar, spelling. You have to have a clear identification of the institute or study, your title, objective at the beginning of the questionnaire. You either have to say it to them before the consent. It's preferable to subdivide your questionnaire into sections, either if it's an online form or in a paper form. Avoid paper form, but if you had to make it into a paper form, also use section. It's kind of helpful. Don't duplicate any question. Avoid leading question, negative question. Don't do double negative inside the question. Allow adequate spacing. Insert the number and text if it's an online form. If it's a long form, it can be off-putting for people to fill it. So try to consider pre-test the questionnaire, the time of the questionnaire, how long it takes to fill in the questionnaire, and try to reduce the question number if you could, to make it as as shorter as you can. Give an ID number for every subject. I think most people don't do that, but ID number will help you. If you have any missing data, you can just go back and check what was the mistake, while either send the filling mistake or just really a missing data. Think about anticipated data analysis. When you do the questionnaire, when you reach the step of making your questionnaire, always think of the data analysis. What exactly the result? What do you want to gain from this research? If you plan your results, you can plan the data collection. For example, sometimes people want a certain result, but they forget to add the question in the questionnaire. So when they reach analysis, they will see a difference between them and other researchers from the same area. So just try to be aware of all the stuff. Can go to the next. Okay. Again. Okay. Give a clear instruction, an example of how to answer the question when appropriate. If the question is hard or you have a fear that people will misunderstand it, try to give them an example. Make it clear again, uncluttered, easy to navigate, with any skip clearly signed. For example, we have a question. If you answer with a no, you can just skip a whole section. So you have to be careful when you when you put these caps. So you don't have a large number of people who didn't answer a whole section. Consider the size and length again. Smaller questionnaire is easier to handle. Indicate that the page turns if it's a paper font. Sometimes people will just put their question. I've seen one of the questionnaire where people have put the question at the last of the page. So some of the choices were in this page and the other choices were on the other page. So people only, people misunderstood the question. They thought they only had two choices. So no one actually answered these choices. So I think it can make it the result can be wrong just because of the way you handle the question. Consider the font, especially if you handle the questionnaire to an elderly population. The font size is very important. Lastly, piloting. Again, piloting can help. Is really great if you have time, or if you could do the piloting. Make sure you do the pilot study before your data collection. It will help you with the analysis, and it will help you to gain a good quality result. Okay, let's go again through the piloting. Again, as we said, piloting is useful to test the data collection process. So you'll be sure you'll make sure that your work is accurate, your question is right, it's the right question to ask. It usually involves trailing the data collection on a smaller sample, as we mentioned, and it will enable you to detect any problem with the data collection, and you can identify and resolve any prior issues prior to the data collection. Also, in the analysis, if you're familiar with the analysis of the piloting studies, we have validity check and reliability check, which basically mean you want to check the questions of your questionnaire. We want to make sure that all the questions are reliable and they're actually answering or detecting the issue that you want to detect for dependent objective or dependent variable. And we also, if you have a section within your questionnaire, you can check whether the questions themselves are consistent with each other. So it's very effective tool. Piloting is it's really good. So you can ask more, ask more about the analysis process and the study design method. I'm sure you'll benefit from it. Okay. Just a summary. What we have mentioned in the presentation: how to identify and classify the data types, to understand the variable rules, dependent, as my colleague mentioned, how to use the appropriate data collection technique, and how to ensure quality for a valid result. Thank you, everyone. If you have any questions, you can ask.
Thank you, Dr. Muram and Dr. Anda. If there is any question or adding something, you can open your mic and okay. If there is no question, you can go ahead for the next presentation. It's about Loom video recording and tutorial. That will be presented by Salahuddin. Dr. Salahuddin, are you ready?
Yes.
Hello? Yeah, okay.
Assalamu
Go
alaikum,
ahead.
everyone. It's really great to be with you all today. So give me a minute to share my screen. Okay, I would like to congratulate Dr. Mayra and best luck in your residency. In addition, thank you, Dr. Ryan, Dr. Yaqeen, Dr. Maram, and Dr. Amna for the wonderful presentations. So before we get started, I would like to make sure that everything is working well. Can you let me know if my voice is clear and if the screen is showing properly?
Yes, everything is clear. Yeah.
Okay, let's get started. Let me introduce myself. My name is Salahuddin Mohammed Abdel Hamid, and I'm excited to walk you through a quick and easy tutorial on how to use Loom. So basically, what is Loom? Loom is a simple tool that helps you to record your screen, voice, and camera all at once. Whatever you are teaching or presenting or just explaining something to your colleague, Loom can make it much easier and more effective. So I hope this session will be helpful and practical for you. So let's get started. To access Loom, open your browser. Here I am using Google Chrome. So you can access Loom by opening your browser and type in the search bar loom.com. So they will open this page. Your first step, you should register and set up your account by clicking in Get Loom for free, clicking this or from here or here. So I will click the Get Loom for free. So the website will redirect me into this page. So you have two options to sign up. Either you can sign up by your email or you can simply sign up by your Google account. I will go for Google account. I already have a Google account. Okay, I agree. You may be asked for a basic info like your name, organization, and purpose of using Loom. So for here, click next. So how you are planning to use Loom? So you use it for education, continue. What would you like to name your workspace? So let's rename it as Salah workspace. Skip it for now. Skip it. So after answering some questions, this page will appear. There will going to be a couple of different ways you could actually use Loom to record your screen. Whether you want it as an extension in Google Chrome or download it as an external tool in your desktop as a standalone application. Well, both of them are free options. However, with some limitations, I will discuss these limitations later on. So there is no big difference between the desktop app and Google extension one, except with some limitation that desktop app give you some more features for recording. So in this tutorial, I will choose using Loom via Chrome extension. It's much easier and easy accessible. So just click on install and you will be redirected in Google Chrome website, Chrome Web Store. Okay. So press add to Chrome, then add extension. It will take some while, 10 minutes. Okay. So this is a Loom homepage. So go ahead and click on the small icon here that look like a puzzle piece to see the extension that have been added. And click on the pin to make it appear next to the search bar. So I will pin it or to click unpin to hide it. So I will pin it. Then make sure that the Loom extension is enabled. Click on the three dots on the top right corner in your Google Chrome. Then navigate to extension. Then manage extensions. And make sure that Loom is enabled. Okay. So let's go start by recording our very first video. At the bottom, you will see the Loom icon. Click on it. As you see, a pop-up window will appear like this one shown here, let me guide you through an available setting. So the first setting here to choose your screen recording mode. So either you will record as a full screen, that will record your entire screen, or you only these tabs, or you can record the camera only. So here I am disabling the camera. If you click on the camera, you will be enabled here. And make sure that your mic is open. So for now, I will record without showing my face. So far, we have just been setting up the recording options. We haven't started recording yet. After that, make sure that your microphone is working. You will notice a wavy lines, wavy lines moving as shown here, which indicate that the microphone is active and picking up sounds. In addition, there is a nice feature that Loom provided to us. 10 minutes. Is blurring. So you can blur anything that may be sensitive information for you, and that will be hidden in recording. For example, if something you don't want to others to see, you can simply blur it by clicking blur and to blur it. So this is a very nice feature. So if we click to start recording, the recording will be started. So let's test it. So when you have your recording setting, click on start recording, you will see a countdown timer. After that, everything on the screen will be recorded, as you see from here. Well, you will see some few control options down there. The first button here is end the recording completely. So when you click on it, the Loom will stop capturing your screen, camera, and audio immediately. Once you do this, the recording session is finished and cannot be resumed. After clicking this button, you will be automatically redirected to the Loom website where your recording video will be uploaded and ready for reviewing or sharing. The next button here, it allows you to pause the recording. It's perfect if you forget something or need a moment to gather your thoughts. Just click it again to resume. Or you can delete it, you can cancel it at all. So I will cancel it for now. Okay, let me try it out by recording a new video. I will act like I'm giving a short lecture to my students about cardiovascular system and talk about shock. This will be a quick 1-minute recording just to show you how useful and easy Loom is to use. So for recording, I will just go to the Loom extension, make sure my microphone is working, and make sure that I am recording my entire screen, and then I will press start recording. So after the countdown finish, you can start talk. So hello everyone, and welcome to today's lesson. I hope you are all doing well and ready to today's topic, which is a cardiovascular system, particularly shock. By the end of this lesson, you should be able to understand what is shock, identify the different type of shock, such as hypovolemic, cardiogenic, and distributive shock, recognize the key clinical signs and symptoms of shock that we need to watch out for a patient, understanding the basic management and principle of treating shock in a clinical setting. So we will talk through each of these objectives step by step, and let's get started. Okay. All right, I will stop the recording now and let's see what's happening. Once you stop the recording, Loom will automatically redirect you and open the video you just recorded directly on the Loom website. So I will press the finish button. As you can see, the page opened immediately and the video I just recorded, it's right there. So let's test it. So hello everyone, and welcome to today's lesson. I hope you are all doing well and ready to today's topic. Okay. The amazing thing about Loom is that it supports artificial intelligence, AI. As you see it, automatically generates the title and the summary of what I have been recorded. So he just give the video the title, which understanding shock in cardiovascular system, and add the summary, what I said. So you can edit the title to whatever you want. Yes. Press enter, and you can edit the summary of the video. In addition, Loom offers many amazing features. For example, here you can edit the audio from there. You can add the captions by enabling this bar. Captions will be added. In addition to captions that can generate a full summary of everything you said in the recording. And you can extract in different formats, like, okay, let's go for generate documents. See what I said, it generated for a whole document. So you can copy it and share it. Or you can even create a ready to send email that you can forward to whoever you want. Just go to generate, write a message. You can email the video to anyone. Okay, to edit the video, you can cut and remove unwanted part. Just go and navigate to edit and trim the video. So here the editing page of the video. So for example, say I would like to remove the first 5 seconds of the video. So just I will click on it and I will highlight all the area that I want to delete it. I will highlight it and press delete the selection, and that will be deleted immediately. In addition, other great feature in Loom is adding things like shapes or arrows while you are explaining something in the video. Here's how we can use it. For example, I would like to add arrow here. I will go to add overlay. Okay, to your video. Okay, we should upgrade it. Okay, we don't have access. Paid access. Once you're done editing and trimming your video, you can press finish button to save your change. However, if you made any mistakes, just click to undo from here and to revert the last action. That way you can easily go back and correct any mistakes without having to start over. So I will go for finish. So here is my video is ready and ready for sharing and downloaded. So you can easily share your video by just clicking the share button here, or copy your link and send it to anyone. I can share it in the meeting, the chat, immediately. You can press share it and choose one of these options to share your video. So that is everything related to Loom and screen recording. The last thing I would like to mention is that Loom offers a 40 days free trial where you can experience all these features. However, features like AI tools and recording videos longer than 5 minutes are typically available with the paid plan after the trial period is over. That is everything, and thank you all for your attention.
Thank you. Dr. Salahuddin. Nice presentation, information. You can go ahead and open your mic.
Okay.
Okay, I see the chat. There is no any question in the chat box. Speak with Dr. Rayan and Dr. Wanda. The topic is cultural to diverse patient population, understanding and addressing health diverse, respecting patient, cultural and religious beliefs. And we are beginning with Dr. Rayan.
Hello,
And Dr.
everyone.
Rayan, yeah, thank you.
Okay, thank you very much
Hello,
for
Dr. Rayan.
everyone
Yeah.
that presented today. And thank you, Dr. Nader, for this amazing opportunity to learn from all these amazing doctors. If my voice is clear, we can start.
Yeah, it's clear and the screen is clear. Yeah, you can go ahead.
Okay, thank you. I am Dr. Rayan Abdulwahab, and I'm going to present the cultural competence in healthcare. Before we started, we have to highlight the importance of cultural competence. Delivering an equitable healthcare to diverse patient population is an essential in a modern medicine. With the challenge of demographic, medical professionals must understand the cultural necessity to improve patient satisfaction and outcome. In a nutshell, cultural competence in healthcare aiming to every patient, regardless of religion background, ethical background, educational background, and every background, that every patient have the right for equitable healthcare delivery. So our objective for today is delivering cultural competency, define the cultural competency, and it is important in healthcare, explore the importance of cultural and religion belief on healthcare delivery, identify a common health disparities and their root causes, discuss the practical strategy to improve the cultural competency, and in the end, we will end with case-based discussion and scenarios. With the start, what is the cultural competency? Cultural competency is the ability of healthcare provider to understand and respect and effectively they interact with patients from diverse backgrounds. What is the importance of a clinical practice in cultural competency? It will enhance the patient provider communication, improve patient satisfaction and trust. This will lead to better health outcome and reduce health disparity. So what is the health disparity? That defines that the health outcome is different between different groups. For example, maternal mortality is more in African American. This may be caused by social determining, systemic bias, language barrier, background bias, and ethical belief and religion belief. So all of these aspects should be addressed when patient come in communication with doctor. So doctor should address any barrier and try to overcome, so will decrease patient mortalities and improve the patient outcome. What is important to understand the cultural diversity? As we know, US is if we can call it, it is an immigrant land. There is a lot of cultural religions background due to a huge number of immigrants every year. In the end, this will lead to different aspects that doctor will deal with. There is an ethical background differences, religion background differences, gender, socioeconomic races, and so others, so that all of these aspects should be addressed by doctor to improve the health and outcome. The social determining, the health disparity and the social determinants of this health disparity include economic stability, as different economic background mean different level of patients, and educational access, communication context, poor environment, and healthcare access. All of this will shape the environment that when doctor came to contact with patients that need to be addressed, so that will decrease the disparity. What is the communication barrier that we have the main communication barrier will be the language discrepancy, along with health literacy. Language disparity, as we said, the different background mean different language. Not all of them are speaking English, not all of them are clear English speaker, and most of them maybe have difficulties in communication and educational level. In addition, health literacy, when patient came to address any medical condition or any medical aspect, should be we have to use a simple, clear language so that all patient will understand and can have a better outcome when came to address his medical condition and understand his problem. So the strategies to decrease this barrier is use of professional interpretation, not a family member, provide a written material in native language, and use teaching path method in which you're the patient and you confirm that he understands, let him tell you back what you was just said. And then we have a cultural allegiance beliefs that there is a different cultural allegiance belief that everyone is going to have, and you should, as a doctor, respect all patients' belief, cultural, religions, education, and so many others, and to balance between the autonomy and the patient belief. This will be discussed more by my colleague, Dr. Wamda, and I will stop sharing that she can share her screen.
Assalamu alaikum. Good evening, everyone. My name is Wamda. I'm a graduate of Faculty of Medicine, University of Khartoum. Today we'll be talking with you about cultural competence. Dr. Rayan already talked about the concept of cultural competence. I will try to discuss how we can apply those concepts practically in patient care, trying to put a general theme and how we can deal with everyday facing cultural differences, whether from our side as physicians or when dealing with patients. Okay. Respecting cultural and religious beliefs in healthcare, there are general concepts, as I will summarize what Dr. Anna Abdelwahab mentioned. We should always ask a patient about their belief in a non-judgmental way and trying to incorporate their preferences into care plan when appropriate, as long as it does not affect the medical management and it does not care no harm, as that may give the patient the feeling that she or he is respected and help building a rapport and a stronger foundation of trust, and that will make the whole treatment plan go smoothly. We try to be flexible and creative when balancing cultural values and medical needs, and involve interpreters, religious leaders, and family when needed. Here are some examples about what cultural differences that may face us. A hypothetical case, Ramadan fasting. A 55-year-old Muslim patient with diabetes insists on fasting during Ramadan. The conflict is the risk of hypoglycemia. Firstly, we approach by educating on healthcare, offer modified medication timing if the clinical status of the patient may allow so, and emphasize religious exemption when health is endangered, maybe ask the family to be involved. This is another example from another culture, the Jehovah's Witness, a 45-year-old patient maybe requiring surgery but refuses blood transfusion. The conflict is the physician believes a transfusion may be life-saving at some point. The approach is we should clarify and emphasize to the patient that we are respecting his or her autonomy, and that it's at the end of the day, it's totally his decision. We could discuss alternative treatment like erythropoietin or cell salvage and talk about how does he or she feel about them, involve ethic legal teams if needed. At the end, if there is no other solution provided by the patient, we could document the conversation and the patient wishes clearly. Another example is SAPTA observance. Maybe an Orthodox Jewish patient refuses elective procedure on SAPTA. An approach, if the case can withstand, we could reschedule if not urgent, or proceed only if life-threatening, and explain an urgency respectfully. Another example, in a Christian family, parent refusing antibiotic for their child due to the belief in divine healing. We should also emphasize that we are respecting the family's belief, but we are also obligated to act in the child's best interest. In this case, we could involve a third party, maybe a social worker or legal support, and follow child protection policies. All of these strategies focus on improving communication and trust. We should use clear, simple language, avoid assumptions based on appearance or accents, use a qualified interpreter when needed, and actively listen and show empathy. Our goal is to make every patient feel seen, heard, and safe. So we can do that using some strategies. There are strategies for providers, physicians, and there are strategies for institutional solutions. As physicians or providers, we start by self-awareness, reflect on our own cultural biases and assumptions, and as we say, treat as you like to be treated, and ask, never assume. Use open-ended questions to explore beliefs and values. Learn from patients. Let them teach you about their culture, and be flexible. Adapt your care plan when possible to meet cultural needs. Use resources, engage interpreter, chaplains, and cultural mediators. Stay updated, attend diversity training, read, and grow continuously. From a point of view of an institution, institutional solutions include that we should provide interpreter services, hire diverse staff that reflect the community, offer training on cultural sensitivity and unconscious bias, and create inclusive policies that honor patient rights and backgrounds, support diversity in leadership and decision-making roles. Dr. Hayam, you can go to slide 9 and 10. Yeah, we talked about institutional solutions. Another part of cultural competence that challenges may face Muslim, Arab, and African physician in residency may be prior time conflict, misunderstanding of modesty, or any other aspects. Always, we should politely communicate the needs, and we could offer flexibility, clarify, and prioritize the patient care always. Stay professional. We could document and seek support, and always inform your coordinator, bring personal equipment as needed. Actually, the concept topic like this about cultural competence may still be deficient from my side. I'm a fresh graduate, so I have little experience, maybe non-clinical approach at all. If any of the doctors or seniors may have any advice, point to share, or any story that can help us. Summary and conclusion. Cultural competence is about listening, adapting, and approaching with respect. See cultural differences as opportunities for better care, and build trust, honor beliefs, and reduce disparities. Thank you for your time and attention.
Thank you very much, Dr. Ryan and Wamda, for nice presentation. Thank you all the presenters, Dr. Mayar, Dr. Ryan, Dr. Yaqeen, Dr. Amna and Muram, Dr. Salahuddin. All your presentations are nice and amazing. That's make more interesting, and thank you, Dr. Nader and Dr. Ahmed. Thank you all the college. Dr. Nader, you want to say something?
Thank you so much. Thank you, Dr. Hiyam and your team. Thank you, all the presenters. And the last item in the agenda is updates. If there is anyone wants to share their progress, or if they have any thing to share to update us, that would be great. Just raise your hand and let us know. In the meantime, I want to share with you, for those who are still interested in applying for residency this year, if you go to the app, you can show the app. There are few, if you scroll this the left, there are some new residency program. One in Texas. So if you click on this, you will have more information and you can contact the director there. And if you go to the last one, there are few new more programs. So if you are interested, please, I think there are 8 of them. So if you have your address ready, your application ready, resume, maybe you can just email it to the programs and you can contact them, see if there is any opening or some spot for you guys. And the other option is to apply for fellowships as well. Any other questions, comments?
السلام عليكم دكتور نادر.
عليكم السلام دكتورة فاطمة. Go ahead.
أنا بس عندي سؤال، أنا انضميت جديد ولسه ما دخلت في واتساب جروب، فبس كنت عاوزة أعرف البروسيس، هل المفروض أرسل يعني ولا؟
So if someone can share the link for the big WhatsApp group in the chat, Dr. Fatma, welcome to the.
كنت كتبت ريكوست بس لسه ما دخلوني.
Now in the chat, now someone can share the link for the WhatsApp group so that you can just click on it and add yourself.
إن شاء الله. وبعد كده الجروبات كيف حيكون التوزيع؟ يعني لما أدخل الجروب الكبير حسأل هناك ولا؟
So basically, as a new fellow, what we do, we assign you to a team, and then each team, they will have a leader, and that leader can discuss with you what you can or what's the next step for you guys. We want you to get oriented with the app itself, and then there are some material or a lot of resources that you can start. It depends on what you know and what you want to learn in the field of research, or we focus on geriatric if you are interested in that, or other specialties. There are few seniors there in different specialties. They can answer some questions or guide you. So this is the organization for you to get involved, and in your team, you can share your time and availability so that you can work together. Let's say if you want to practice interview session, if you want to practice small presentations together, if you want to discuss any topics together, how to improve your whatever skills that you want to, your resume, if you want to have someone look at it and see if they have any feedback. So this is just the first step of organization. The second part is we have project-based kind of structure where we want you to get involved in at least one research project. So there are few projects in the list in the app. You can see if you want to join any of them, if they are active, or if you want to start, if you have an idea. Let's say you have some experience and you come up with new idea. We can work to create a team, and you work with that team to accomplish or complete the project. The idea is we want you to apply the knowledge that you know or you learn during the process or during your time here, and hopefully you will benefit and you will have a product at the end of the fellowship program. Thank you.
إن شاء الله. شكرا دكتور. وكيف ممكن أتواصل مع الليدر ولا هو حيتواصل معي؟
They will contact you.
أوكي شكرا دكتور، يعطيك العافية.
Okay, if there's no more questions, I'd like to thank you again, all the presenters, Dr. Hiam, and all those who joined today. Thank you, Dr. Ahmed, and those who will come and review or watch the recording in the future. Thank you. Have a wonderful day, and we'll see you next week. Assalamu alaikum. You can reach me and you can contact me via email or call or text. I'll be happy to help as much as we can. Thank you. Assalamu alaikum. See you next week.
Thank you, Dr. Nadia and Dr. Ahmed and the presenters. Have a good one.
Have a good one, Dr. Fak.